Welcome to Principles of Evaluation and Applicability to Public Health Emergency Preparedness. This course, created by Dr. Elena Savoia, has been developed based on the content of 4 documents: Introduction to Program Evaluation, a self-study guide created by the U.S. Centers for Disease Control and Prevention; the Project Program Monitoring and Evaluation Guide, created by the International Federation of Red Cross and Red Crescent Societies; the Evaluation Practice Handbook, created by the World Health Organization; and the W.K. Kellogg Foundation Logic Model Development Guide. The links to these documents can be found in the notes to this course. Hi, my name is Atsumi, and I'll be your guide for this course. I'll first introduce you to some common definitions, then talk about the different evaluation approaches, discuss different types of logic models, and conclude with the use of indicators. In public health emergency preparedness, we have several complex activities designed to prevent, protect, respond, and recover from a public health emergency. Such activities are commonly described as capabilities. This CDC document lists the number of capabilities that a public health system may be requested to execute in preparation or response to an emergency. If you scroll down the page, you'll find examples on how to conduct surveillance and epidemiologic investigations, emergency operation coordination, and emergency public information and warning. Since these are complex activities, they can clearly be divided in sub-activities. Depending on the evaluation goals, these activities can be judged in terms of their effectiveness, relevance, efficiency, and so on. Let's take a look at Patton's definition of program evaluation. Program evaluation is the systematic collection of information about the value of activities, characteristics, and outcomes of programs. This information is used to make judgments about the program, improve program effectiveness, and/or inform decisions about future program development. Next, let's see how this definition applies to the evaluation of public health emergency preparedness programs. Let's see what can be evaluated: effectiveness, including coverage and sustainability; efficiency, coordination and coherence; relevance and appropriateness; and equity. In emergency preparedness, we could evaluate the effectiveness of a risk communication campaign or sheltering operations. We could measure the efficiency of releasing information to the public or across agencies, the coordination and coherence of information from multiple responding agencies, the relevance and appropriateness of the interventions being implemented with respect to saving lives and protecting properties, and the equity of access to resources or information across the population. When we evaluate the effectiveness of a program, we seek to answer the general question: what difference did the program or intervention make in practice, and measure if the intended objectives were achieved or if beneficiaries were truly helped by the products or services made available. More specific questions could be: how well were the objectives achieved? What results were achieved based on an analysis of key indicators and standards? To what extent did the targeted direct and indirect beneficiaries actually benefit from the intervention? What do beneficiaries and others say about the value, quality, and quantity of the project? Effectiveness can also be measured in terms of coverage. Was the targeted population reached? As well as sustainability. Are the changes that have been achieved likely to be sustained? But how is effectiveness different from efficacy? These two concepts look similar. Effectiveness refers to programs' effects when delivered under real-world conditions. For a program to be effective, all the efficacy conditions and criteria must be achieved, including a clear theory of causal mechanism. In addition, there must be detailed information for whom and under what conditions the program or intervention works. Finally, there must be details on the delivery of the program, including manuals and other technical support used in the execution of the intervention, as well as information on associated costs. When we evaluate coordination, we examine if the actions of government and agencies are aligned with each other. More specific evaluation questions could be, were plans for coordination in place and followed? Was a lead agency appointed? Which parties were included and in what manner? What were the main constraints and supports to coordination? Did coordination lead to improved effectiveness and impact? We can also assess coherence. To what extent were the policies of the actors involved complementary? Relevance and appropriateness refer to consistency of a project or program with population needs. Does the project or program make sense? Do we have the right capacity to conduct activities that are relevant and appropriate? And are we doing the right thing? When we evaluate efficiency, we seek to answer the question, could similar results have been achieved by other means at a lower cost? More specific evaluation questions involve measuring the time and resources expended to reach our objectives. Additional questions include, could these results be achieved with fewer resources? Have the objectives been achieved at the lowest cost? What problems might have reduced efficiency? What opportunities were missed to increase efficiency? Were the right staff and materials available in the right place at the right time? Let's consider equity. Have the principles of gender equality, human rights, and equity been applied throughout the intervention? Was data gathered in a way that can be broken down into separate populations that did and did not have equal access to the intervention? Before we even start developing an evaluation plan, we need to clarify the purpose of the evaluation. Who wants the evaluation? Why do they want it? And how do they intend to use the results? For this reason, the first step in the evaluation process is to engage stakeholders. Stakeholders are people or organizations invested in the program, interested in the results of the evaluation, and or with a stake in what will be done with the results of the evaluation. In public health emergency preparedness, we have identified 3 scopes: accountability, system improvement, and research. Measuring for accountability purposes involves comparison of performance across jurisdictions or agencies and requires a high-level standardization of methods and measures. On the other hand, when measuring for quality improvement purposes, organizations are more interested in identifying specific flaws and limitations in their plans and systems so that those problems can be addressed before the next emergency occurs. In these instances, the evaluation data gathered and presented are detailed and very specific to the organization and environment. Data used for quality improvement give answers to questions such as what went well, what went wrong, and where was the plan inadequate? The 2 scopes, accountability and system improvement, may overlap. When evaluating for research purposes, the main interest is simply in discovering new relationships or trends. In the spirit of monitoring system improvement, evaluation can help identify important factors that, if changed, may improve one of the outcomes: effectiveness, relevance, appropriateness, and equity. There are a number of different types of evaluation approaches: process evaluation, formative evaluation, outcome evaluation, and impact evaluation. Each can be applied in different ways to public health emergency preparedness. Process evaluation assesses the process of program delivery. Process evaluation questions may include how many participants were recruited, how many people were reached by the program or intervention, how many resources were required and used by the program, how were the quality standards attained. In public health emergency preparedness, a process measure could assess how many public meetings were hosted by a public health agency to inform the public of a particular threat, how many brochures were distributed, or how many people were vaccinated. Depending on the capability being evaluated and public health intervention executed, there could be several different types of process measures. The magnitude of exposure to materials and activities, the initial use and engagement in program activities at the start of the program, the continued use of activities over time, and the attainment of quality standards. Formative evaluation is part of process evaluation and refers to evaluation activities undertaken during the design and pre-testing of a program to help guide the design process. More specifically, it refers to the use of initial process evaluation data by program planners so that adjustments to the program can be made if necessary. Formative evaluation can be particularly useful for several reasons. First, it fosters an understanding of the causal events leading to change and the specific components of the intervention that most influenced it. Second, it helps us understand the experience of those directly affected by the implementation efforts. Lastly, formative evaluation contributes to standardizing ongoing implementation. Next, we'll examine outcome evaluation. Outcome evaluation investigates if a program had a demonstrable effect on a defined target outcome. Impact evaluation examines the effect of a program on factors correlated to the main outcome, such as policies, behaviors, or attitudes. The proper analysis of impact requires a what-if type of analysis. What changes might have occurred if the program or intervention was not in place? Otherwise, as depicted in this cartoon, you risk jumping to conclusions and incorrectly attributing change solely based on your program. This can start to be confusing. What's the difference between outcome and impact evaluation if they both examine the effects of the program or intervention? Outcome analysis requires specific objectives to be set at the beginning of the program or intervention. One example objective might be an intended vaccination coverage of 60% in a specific population. Impact evaluation, on the other hand, may focus on both intended and unintended consequences, giving a broader analysis of the effects of the intervention. Let's look at an example of impact evaluation. If a specific population accesses a clinic for vaccination, they may also gain access to other services during their flu clinic visit. Access to these additional services is a measure of impact. Let's move on to logic models. Logic models help you map where your program or intervention is headed. Planning and evaluation go hand in hand. Therefore, an evaluation logic model needs to be developed early in the planning phase. A logic model is a systematic and visual way to present and share your understanding of the relationships among your program resources, your planned work, and your intended results. The components of a logic model are input, output, outcome, and impact. Inputs include resources such as a program's human, financial, organizational, and community resources. Another input are the program activities, the processes, tools, events, technology use, and actions that are an intentional part of the program implementation. Outputs are the direct products of program activities and the services to be delivered by the program. Outcomes are the specific changes in program participants' health, behavior, knowledge, skills, etc. There may be short-term outcomes, 1 to 3 years in length, and long-term outcomes, 4 to 6 years in length. Impact is the fundamental intended or unintended change occurring in organizations, communities, or systems as a result of program activities within 7 to 10 years. These changes can be organizational, community, or systemic. The logic model component occurs in sequence. Outputs are derived from inputs, the program's resources and activities. Outcomes are measured after output. A program's impact is typically assessed at a later point in time, after the implementation of the intervention, but, depending on the length of the project, could be assessed at different times and eventually even at the same time of the outcome. There are 3 main approaches to the development of logic models. Theory approach models give a big picture of the program or intervention. Outcomes approach models are often used for reporting purposes, as outcomes are developed with a theory of change in mind and focus on specific resources and activities. Activities approach models are good for management and monitoring, mapping the process of program implementation. Theory approach models are designed to give a big picture of the scope of the program, the ideas that went into the conceptualization of the program, and emphasize the change expected by implementing the program. Such models describe what we hope to do, how we will do what we say we will do, and what we have done so far. This is an example of a theory-based logic model related to vaccine distribution during the 2009 H1N1 influenza pandemic. The goal of the intervention was to promote partnerships to increase vaccination coverage and equal access to the vaccine across the various segments of the population. The planned work included meetings with providers, payers, and pandemic planners. Activities included active participation in the pandemic planning process and inclusive community decision-making. Intended results were a more effective outreach to the population and engagement of a larger number of providers. Outcomes included community-wide coverage and improved equity. The impact was assessed in terms of improved population health. This model is an overview of the factors that produce change and does not describe the specific nuts and bolts of the H1N1 intervention. For this type of model, any assumptions need to be described. In this case, 2 important assumptions included motivation of providers to participate in the initiative and timely distribution of the vaccines. Here's an example of an outcome approach model based on the same H1N1 intervention. Remember, the goal of the intervention was to promote partnerships to increase vaccination coverage and equal access to the vaccine across the various segments of the population. Let's focus on one input and its relationship to planned activities, outputs, outcomes, and impact. As an input, providers, players, and pandemic planners participated in planning efforts. Activities were organized to encourage the participation of all these groups. An output of these meetings was the agreement on how to distribute and administer the vaccines. This led to an outcome of increased availability of providers administering the vaccine. Finally, the impact ultimately increased population coverage. In an outcome approach model, linkages are identified for all inputs and activities included in the implementation of the intervention. Now, let's look at the H1N1 example using an activities approach model. This model lists the detailed activities needed to achieve a specific output and outcome, and maps the activities to the outcome and milestones. In this model, providers, payers, and planners are first identified, along with high-priority communities in need of improved access to the vaccine. Documents are reviewed, and in Milestone 1, gaps are identified. Subsequently, meetings are organized to achieve new agreements and contracts. This type of model is very useful for managing the project and tracking changes and progress over time. The activities approach model typically uses charts with timelines and staff assigned to each step of the process. What are indicators? An indicator has two main components, the metadata and the data. The metadata is the title of the indicator, for example, the infant mortality rate, and how the indicator is defined, for example, the number of deaths of children aged less than 1 year for every 1,000 live births. The data is the numbers that are fed into the indicator, for example, 56 deaths of children under the age of 1 in a community where there have been 4,963 live births. We use 5 criteria for SMART indicators. They must be specific, measurable, achievable, relevant, and time-bound. The first criterion for an indicator is to be specific and sensitive. Indicators are specific when they measure what they claim to measure and are not confounded by other factors. This is also referred to as validity. Sensitivity refers to the ability of the indicator to capture changes in a situation. These changes can inform decision-making in a timely manner. Now, here's a question about specific indicators. Is the following indicator specific or valid to measure household preparedness? Click True or False to submit your answer. The second criterion is being measurable. Indicators must be precisely defined so that their measurements are unambiguous. We can use quantitative measures such as percentages, ratios, and numbers, and can also use qualitative measures such as level of risk or level of agreement. Being measurable also means being reliable, comparable, and contextually appropriate. All these characteristics reduce ambiguity. Here's a question on reliability of indicators. Which of the following 2 indicators is a more reliable measure of household preparedness? Drag the most reliable indicator in the box below and click Submit. The third criterion is being achievable. Is there an institutional capacity to collect the data? Are there agencies, organizations, and staff available for data collection and willing to do so? Finally, is the data collection affordable and worthwhile, and is it safe to collect the data? The fourth criterion is being relevant. Will this objective have an effect on the desired goal or strategy? Relevant relates to the relationship between the objective and the goals of the program or purpose of the intervention. Evidence of relevancy can come from a literature review, best practices, or your theory of change. For example, if a program aims at increasing the vaccine coverage for a specific disease, an indicator measuring the number of residents having access to cancer screening may not be relevant. The fifth criterion is being time-bound. Indicators should describe when change is expected. An indicator needs to be collected and reported at the right time to be useful for decision-making purposes. A specified and reasonable time frame should be incorporated into the objective statement. The time frame should consider the environment in which the change must be achieved, the scope of the change expected, and how it fits into the overall work plan. An example, an indicator might be, by December 2010, the program will achieve the following goals.